ORDI. So today we have Dr. Gauri Krishna. She is a UK trained pediatrician and clinical geneticist with over 10 years of expertise in inherited metabolic and neurometabolic disorders. She holds an MPhil in medical genetics from the University of Cambridge and is board certified in pediatrics and metabolic medicine, CCT UK. She currently practices as consultant in pediatric genetics and metabolic medicine at St. John's Medical College, IGICH, Rainbow Children's Hospital, Cloud9, Baptist, and People Tree Hospital in Bangalore. Her clinical and research focus includes lysosomal storage disorders, organic acidemiasis, and transplant outcomes in metabolic diseases. She has led international studies and trials in Niemann-Pick disease, AADC deficiency, and X-linked hypophosphatemic rickets. Dr. Krishna combines academic rigor with a commitment to accessible to empathetic care for children with rare disease across India. I'm very pleasured and I'm very happy to introduce her. Ma'am, over to you, ma'am.
Hi, I hope you can hear me.
Yes, ma'am. Yeah.
Just put my phone on silent 1 second, sorry. Right. Okay. So, good afternoon, good evening, everyone. Thanks for joining in. Hopefully, what we will be able to go through in this session is early recognition, rapid intervention, and long-term neuroprotection of children with urea cycle disorders, and probably adolescents and adults as well. So why do UCDs matter so much in acute care? And this is really important because it's the most important cause of severe neonatal hyperammonemia. It typically presents after initiation of feeds within 24 to 72 hours. It causes rapid neurological deterioration if untreated, and early recognition is neuroprotective. So that's really critical, and that's why it matters so much. And just a very brief overview of what urea cycle disorders are. So they're inborn errors of nitrogen metabolism, and they're caused by defects in enzymes or transporters involved in converting ammonia to urea. So there are lots of enzymes in the liver, especially in the periportal area, both in the cytosol and the mitochondria, enzymes that are involved in detoxifying the ammonia. We know that ammonia is neurotoxic and can be fatal, and this is a time-critical metabolic emergency. So I thought we just have a very, very brief sort of overview of the pathway. I've not gone into very rigorous diagrams because it always confuses people. I thought I just want you to understand the basic concepts, and perhaps we can, build on that later. So we know that it is this urea cycle is the primary pathway for detoxification of ammonia in the liver. And there are lots of ways in which it's done. Some of it is done in the mitochondria, some of it is done in the cytosol, and the enzymes are distributed across. It converts the toxic ammonia into urea for renal excretion. And as I said, it occurs across mitochondria and cytosol of hepatocytes. And the defects in any of the enzymes that are responsible for the conversion of ammonia into urea leads to hyperammonemia with neurological toxicity. So I just thought it would be just to get familiar with the names of the enzymes. So the mitochondrial urea cycle enzymes are carbamyl phosphate synthase, N-acetyl glutamate synthase. So that's NAGS, which is an essential activator of CPS1. That's really important. The ornithine transcarbamylase and carbonic anhydrase. So this is an ancillary enzyme supplying bicarbonate. So sometimes you can have hyperammonemia where you don't get all of the other abnormalities that you would expect with amino acids, and you should think about the carbonic anhydrase as well at that point. The cytosolic enzymes and transporters are the arginosuccinate synthetase, the arginosuccinate lyase, arginase, and as I said, the other one is mitochondrial transporter. So these are the cytosolic enzyme, and the last one is a transporter. So you can have a defect in any of these that can lead to hyperammonemia. Okay, so just a very brief thing. When I said, ancillary enzymes, I said, there could be other things that can also cause hyperammonemia, and it's important to distinguish that from a proper urea cycle defect in the sense of the enzymes that we discussed before, abnormalities, genetic abnormalities in that. So you can have what we call ancillary enzymes and related disorders. So one of them is P5CS, where you can have hyperammonemia, and treatment is different. Carbonic anhydrase deficiency, transient hyperammonemia of the newborn, and important mimics and modifiers of classical UCDs, which could also be cofactors and other things that might be involved. So that's really important to understand. Now, ammonia enters the urea cycle in the liver. There are sequential enzyme steps that convert ammonia into urea, and the block at any step can lead to ammonia accumulation, and that's really important to understand. The proximal defects cause low citrulline and high ammonia, and the distal defects cause high citrulline or arginosuccinate. So you can differentiate between proximal defects and distal defects by just looking at the citrulline levels. So we're just going back to why ammonia matters. It crosses the blood-brain barrier, leads to edema, raised intracranial pressure, as well as seizures and coma and death. So it's really important. As I said, this is a critical metabolic emergency, and earlier diagnosis and treatment always has better outcomes. One of the things that you will see is that we do have a lot of, especially the mitochondrial enzymes, they can cause sort of intermittent elevation of ammonia, which can cause cognitive impairment long-term, developmental delay, and behavioral problems. And that need not be associated constantly with, an ammonia level which is measured as high. So it could be intermittent, and we need to really assess them properly with using plasma amino acids in conjunction with ammonia. And of course, if we don't treat it correctly, it causes irreversible neurological injury. So what's the epidemiology? Global versus India. Global incidence is 1 in 35,000 live births. Indian burden is likely higher because of the high birth rate, consanguinity, and endogamy. We have a limited universal newborn screening. Now we have a whole spectrum of clinical presentation, and I think every sort of age group has a sort of, again, it's all time critical, and it's really important that we identify it early and make sure that we don't get to irreversible neurological injury. One of the things, obviously, there can be adult onset. I do look after adult patients with IMD, and very often they present just with psychiatric symptoms. And I think if there are some red flags in terms of, sudden acute presentation, waxing and waning features, or any regression, I would strongly recommend that we do a plasma amino acid and ammonia in adults as well. So the neonatal onset, I think if you've got a lot of pediatricians and neonatologists today, you will know that poor feeding, lethargy, and cephalopathy, it's toxic. Ammonia is toxic to the brain, so that's how it appears. Infant and childhood, it's usually episodic vomiting, altered sensorium. And as I mentioned, adolescents and adult symptoms could be predominantly psychiatric. The triggers could be infection, fasting, even postpartum state. I recently had a lady with OTC deficiency who first presented in the postpartum period. That was her first presentation ever. And she's done well. And thankfully, at that point, she had a baby girl. But we were able to get to the bottom of everything. And now we have a diagnosis in case she wants to get pregnant again. And she's on treatment, and her daughter's has been tested as well. So I think that's really critical to understand that this can present at any point, especially partial enzyme deficiency. So why does this topic matter so much in India? And I've already mentioned that, we've got a lot of adults presenting. We have a high burden of disease, which we've not really gotten to the bottom of because of all of the factors I mentioned before. And also we have an increasing survival into childhood and adulthood, generally because our nutrition has improved, our infant mortality rate has decreased, maternal mortality rate has decreased. So generally our population is living longer. So there's greater availability of metabolic and genetic testing, but we do need a really unified, uniform, universal Indian-specific protocol, and obviously continuously training frontline clinicians is critical. So lots of times UCDs could be missed in India because they can be misdiagnosed as sepsis and HIE, especially in places where you don't have easy access to testing ammonia or even blood gases. can be considered as acute liver failure or encephalitis in a lot of population, especially if the ammonia has not been checked earlier. And we probably have a low index of suspicion for metabolic causes. So there is a diagnostic gap in the Indian setup because of the ammonia testing, limited access to metabolic investigations, which can be very expensive, over-reliance on imaging and sepsis markers, and the genetics could be pursued late. Again, all of these have both logistic as well as economic problems, especially because lots of the genetic tests are not covered by insurance. So why is early recognition critical? Hyperammonemia is treatable if identified early, and delays cause irreversible neurological injury, which we know. And treatment should begin before genetic confirmation because the outcome depends on the speed of intervention. So when do we suspect a UCD? A term or near term in neonate initially develops poor feeding, vomiting, lethargy the moment they are introduced to breast milk, which is a bit of a protein load. And then they develop seizures, hypotonia, and coma. One of the things that we do understand is they often present with respiratory alkalosis with no clear cause. So the golden rule is if you've got unexplained encephalopathy, seizures, lethargy, just check a plasma ammonia. And if the ammonia is above 150 micromoles in a neonate, it is abnormal. And treat this as a metabolic emergency. Do not wait for diagnosis. So I've just sort of tried a cube, which is, I hope it can be complicated, but we're going to try and simplify it quite a bit. So I did mention that, you have the high defects where you have low citrulline and the low defects which have a high citrulline. So in the cycle, the two amino acids that you urgently need to look for are arginine and citrulline. And if they look abnormal, forget the point of enzyme defect, you know that you're dealing with a urea cycle defect. So that's really, even a low citrulline should sort of make you, so something doesn't need to be always high. A low level also should trigger, especially in the presence of hyperammonemia and encephalopathy, should trigger you thinking about urea cycle defect. Now, when we did go, and I'll just sort of reiterate this, we've got low citrulline, high ammonia, high citrulline, or the other one you can look at is arginosuccinic acid or elevated arginine. The point I'm trying to make is it doesn't always have to be a high level for you to worry that it is a UCD. Even a low citrulline in the presence of high ammonia should trigger a urea cycle defect pathway problem. So I think one of the conditions specific, this we will come back to, but just keep that in mind, especially with those levels. I want to discuss this, but we'll do it at a later on. So the management principles overview, rapid ammonia reduction, really important. You have to prevent catabolism, long-term nitrogen control, and a multidisciplinary team approach. I'd rather be told earlier and contacted earlier than later because ICU management is critical in all of these time-critical metabolic conditions. So the idea is just stop all protein, nil by mouth, urgently, start IV 10% dextrose. You must stop the catabolism. So you go up to a high GIR, so go to 6 to 8 or 6 to 10, I don't care. And if the sugars start going up, use insulin. But the idea is to reverse the catabolism, so go up quickly on the fluids with 10% dextrose. Add intralipids if needed to increase the calories. You have to basically prevent the catabolism. And I think that's the key thing. All of the sodium benzoate, all the fancy drugs come in much later. The first most important thing to think about is to prevent catabolism. And of course, you do all the other things, secure airway, manage seizures, and add ammonia lowering therapy in parallel. So this is a really nice chart that I like. So if it's 150 to 250, what are we going to do? We're going to do medical therapy and close monitoring. If it's 250 to 400, I would look at aggressive scavenger therapy plus ICU care. Anything more than 400 to 500, you have to do urgent dialysis. No question of waiting here at all. So the sodium benzoate is first line. It's widely available. Arginine only if we know it's a distal UCD. I would avoid arginine till we are sure. Citrulline, if it's proximal UCD, again, these two I would wait till I know more. The most important, these could be done a little later on when we have a genetic diagnosis. The primary issue is we have to prevent catabolism. Carbamyl glutamate is ideal for NAGs and CPS1. It's very expensive and not available. And of course, phenylbutyrate again. So I think these two drugs are things we need to get into Indian market really quickly. I don't know if anyone else knows if they're available, but I've had no luck in sourcing these two medications. So this is the general dosage. Of course, we don't have IV. So most of this, they're similar in terms of the IV oral dosage. And whenever in doubt, you load them with 250. You can go up to 500 mg per kg per day and then per kg, and then you start giving it per day in 3 divided doses. So ammonia, I think then you have a decision algorithm with dialysis. If the ammonia is not falling within 4 to 6 hours of starting medical therapy, or if it jumps up to 400 to 500, or if there's more clinical deterioration with cerebral edema, these all mean you initiate hemodialysis. And I know hemodialysis is not easily available. I'm also happy for peritoneal dialysis to be started. So one of the things that I really want to reiterate here is you don't have to wait for the ammonia to go up to 400 to 500. If they are not responding to standard medical therapy within 6 hours of initiating, as in, you've prevented the catabolism, you've given the ammonia scavenger therapy, and there's still clinical deterioration in cerebral edema, that is also an indication to do dialysis. So this is sort of a snapshot of what I was saying earlier. And I think if we follow this pretty decently, it's a great place to start off. And I understand the hemodialysis is not available, but I think peritoneal dialysis at our level works. I'm hoping at some point we get to a centralized hub and spoke where, if things are not improving in 4 to 6 weeks, then they're able to be transferred to a place where we can have hemodialysis. And I think that is critical in how we manage these conditions. So the key take-home message here is hyperammonemia is neurological emergency. Early treatment saves brains. Always start management before confirmation. And sort of, if it's in the NICU setup, NICU genetics, dietetics always has better or even best outcomes if it's diagnosed pretty quickly. So the common pitfalls are looking for metabolic acidosis. As I said, you can have respiratory alkalosis in this condition. Delayed ammonia testing, feeding protein during crisis, or a late referral to metabolic or genetic services. So these are the common pitfalls within the Indian context of managing children in the ICU with a newly diagnosed urea cycle defect, or even a child decompensating with a known diagnosis of UCD. So the role of genetics in NICU and beyond, it confirms diagnosis and subtype, which is critical, especially when you're determining long-term treatment strategy. It enables recurrence risk counseling, which is really critical, especially given the rate of endogamy and consanguinity in our population. And of course, allows for prenatal and pre-implantation genetic diagnosis in subsequent pregnancies. Now, after stabilization, the chronic care includes controlled protein intake, UCD-specific formula with essential amino acids, long-term scavenger therapy, and regular ammonia and amino acid monitoring. And this is really important. These are sort of the pillars of management in long-term chronic care. And that does include monitoring their nutritional status, ammonia and amino acid monitoring. It has to be done every 6 months because that allows us to fine-tune and tailor diets. Also, children can be fussy. Anybody can be fussy. And it's really important that we're getting the right treatment along. And with the fact that we've now got gene therapy for one of the urea cycle defects, we're definitely going to catapult into a lot more things. And I think keeping our babies really healthy and keeping their brains intact before we can access these kind of curative therapies will be critical. So chronic care cannot be undermined in any way, shape, or form, and it's best managed by a metabolic physician. So other thing I wanted to discuss today was liver transplant, because I think going forward right now, that would be one of the options we should start discussing with parents, especially now that newborn screening has become more available, so has genetics, and we should be able to have a cohort that has preserved brain or limited neurological injury, that we can offer liver transplant. So one of the sort of things that we need to look at are neonatal onset severe OCDs, recurrent hyperammonemic crisis, poor metabolic control, or despite therapy, and the fact that it could be curative, but of course the timing is very critical. So liver transplant is a neuroprotective intervention, and it's not a treatment for liver failure. It replaces defective hepatic urea cycle with functional one, and the idea is it prevents future hyperammonemic crisis, and the timing determines neurological outcomes. So this is really important to understand. So we're not going to offer it to everybody, all and sundry. There has to be a clear pathway and procedure where we determine which patients will benefit most from this condition. Because liver transplant is not a small procedure. It is quite a significant procedure requiring immunosuppression and uptake and things like that. And the parents really need to work very hard 1 to 2 years post-transplant to make sure that this work is working for them. So I think that's really critical to understand as well, that we can't just take every child with the UCD and do liver transplant. We have to be very clear about which kids are going to benefit most from doing this this intervention. So especially in the Indian context, timing matters a lot because where there's a high reliance on living donor liver transplant in India. So it allows elective planning rather than crisis-driven decisions. And this is very key, especially since I've started looking after more of these children here. I think whenever we're advising families, we have to be very clear as to why the timing matters so much in the context of the Indian population. Of course, there's limited universal newborn screening, so that's another issue. So we have to be very clear, in the absence of universal newborn screening, how best are we going to serve our patients and what the timing will be with liver transplant. The other thing is, of course, variable access to emergency metabolic care across regions. So all of these things are very relevant when we're looking at timing, especially in our country. So who should be referred early for LT evaluation? Any neonatal onset severe UCD with ICU admission should have a look into early LT liver transplant. If there's recurrent hyperammonemia crisis despite optimized medical therapy, any episode requiring dialysis, and evidence of neurodevelopmental plateau or regression. So that's really important to think about. So the best time is when the child is metabolically stable, and that's really important before cumulative irreversible neurological injury occurs, and not during any active hyperammonemic crisis, and only after nutritional and infection optimization. And this is really critical. And that's why I keep harping about the universal newborn screening, training more acute frontline critical care physicians. And the idea is, at the end of the day, to try and preserve neurological or cognitive outcomes, prevent active hyperammonemic crisis, and make sure that their nutritional state is optimized, and of course, infection control by adequate vaccination. So the idea is to discuss LT evaluation after one severe ICU level hyperammonemic episode. So you strongly consider listing after recurrent crisis or a dialysis requirement. And we plan elective transplant once medical therapy no longer ensures safety. And of course, the decision should always be multidisciplinary and family-centered. And this is really critical. It's very important that we stop working in silos. We discuss with colleagues who have different expertise and find out how best we can make it all work. So, getting the liver transplant team involved, involving neurology, involving genetics, involving metabolic medicine, involving dietitians. All of this is critical in ensuring the best possible outcome for our patients with urea cycle defect. So the earlier LD, why is it necessary in the context of India, is because living donor availability allows planned timing, avoids long diseased donor wait times, and reduces cumulative neurotoxicity risk, and we do have more predictable perioperative outcomes. So that's really critical in understanding as well. Okay. So what does liver transplant fix at the end of the day? Okay, sorry. So this prevents most future hyperammonemic episode. It normalizes ammonia, handling rapidly post-transplant. So that's really important. So the ammonia just completely normalizes, and this is really important once the liver transplant is successful, and it improves survival and metabolic stability. What it does not fix, this is really important. That's why I keep harping about making sure that we've identified early and treated it early. This does not reverse existing brain injury, does not normalize extrahepatic urea cycle activity, does not eliminate need for neurodevelopmental follow-up. So the LT is not an emergency rescue, but a planned neuroprotective strategy. Earlier transplant can preserve developmental potential. Waiting carries a real risk of irreversible brain injury, and decision balances surgical risk versus lifelong metabolic risk. So that's really important to understand. So we just need to get the balance correct as to early diagnosis, early referral, as well as neuroprotection in terms of trying to make sure that the child has the best surgical risk versus lifelong metabolic risk. And this sort of cycle is really important to understand. And I think I would recommend that if you've had a child who's required all of these severe interventions, is that you refer them early to a metabolic specialist so that we can do a risk strategization for making sure that we get them the right help, make them meet the right team in terms of transplant, and make decisions earlier. And that's really important. And that it also, as I said, involves optimization of the nutrition as well as infection risk. So the take-home message from this particular thing is think of LT early in severe or recurrent urea cycle defects. Refer before irreversible neurological damage accumulates. Indian LDLT model allows proactive timing, and goal is brain protection, not biochemical perfection. And that is the key message. We're really trying to protect the brain and not get some amazing values in amino acids. So at this point, I don't know if you have any questions. And I'm happy to take them.
Yeah, thank you, Dr. Krishna. It was a clean, neat, and insightful presentation. I just want to know, I'm curious to know that in inherited urea cycle disorders, basically, the pattern of urea cycle disorders influence the age of onset, basically. And the severity of hyperammonemia. So particularly in X-linked versus autosomal recessive forms. So how do you look at this?
So as I mentioned, the OTC, which is the X-linked disorder. Let me just go back. So they can present, especially in women, they can present at any age, and they can present symptomatic OTC. Females are really very common, and they usually have a massive stress. It's usually, periods, heavy flow. Suddenly, when they attain puberty, until then they're fine. They may have mild cognitive delay, but it's not very significant. And the other one is pregnancy and postpartum. Those are the three critical stages, and it's all due to X inactivation. Obviously, male OTCs are very severely affected, and it's a neonatal presentation. But this I'm talking about X-linked female. Also, partial enzyme activity preservation, especially in lots of these compound heterozygotes, where you can have, when you see it in lots of these families where they're not homozygous, not consanguineous, there's a compound heterozygosity. Especially classical citrullinemia, there's a lot of compound heterozygosity in Indian population. These children have partial enzyme activity, so they tend to be all right. And for them, especially, the amino acid is not diagnostic. You need to get genetics for these children. So there is a sort of, even within the urea cycle defect, there's a whole spectrum of things happening, whether it's a mitochondrial urea cycle enzyme or a cytosolic urea cycle enzyme. All of them are autosomal recessive apart from OTC, but all of these can have a whole spectrum, and that's why you can have presentation, as I said, as adults as well with psychiatric manifestation. So always keep an open mind about ammonia. And if your ammonia is fine, but there's still you have a high suspicion, and you've got to time the plasma amino acids correctly. Sometimes give them a bit of protein load. So you have all of these challenges that you can do, but they have to be done under guided supervision. And then you can also get them sort of precipitate this and interpret the amino acids while you're waiting for genetics, especially the older population. So even within the urea cycle, you can have a spectrum. So never forget that, and never forget it as a metabolic emergency. Always test it because these are treatable. And that's the key message. These are treatable. We can fix it to a large extent, and compliance, especially when we get them early, is very high with urea cycle defects.
Exactly. Understood. Yeah. So I hope I'll check the questions, Q&A. Yeah. So because he's asking that, what is the role of diet modified in UCD? How many children born with UCD in India every year? IVR transplant / diet modified, which is better?
Of course. See, as I told you, the question I want the person who has asked is, at what point did you diagnose it? How much neurological injury have you prevented? And how many admissions in the past year have they had being on diet?
Right.
Those are the 3 questions I want every clinician to ask themselves. And if you are in doubt, please refer on, because that's the idea, that we talk to each other. The whole idea of having these CMEs or talks is so that we know that we can approach each other when in doubt, because at the end of the day, we want to do our due diligence and best for our patients. Right. But those would be my 3 questions to ask. There is no LT versus diet. It's not a competition here. What we're looking at is, if the child is decent, if any of those other things happened, neonatal UCD requiring ICU care, requiring hemodialysis, requiring intense, all of them should ideally be referred on to look at LT. Because what it means is there's nothing, there's no enzyme there.
So you're asking the same, what is the accepted value of ammonia if children suffering from UCD?
So ammonia there's no accepted value. So that's a good question. I don't know who asked it. We are not, as I said, we're not treating biochemical perfection. Mm-hmm. The better assessment of good control, dietary control, is glutamine level. Okay. So ammonia is based on ice, based on squeezing, based on a lot of things. So there's no perfect ammonia level. My better assessments are, how are they doing neurodevelopmentally? What is the glutamine level? And of course, nutritional status, B12, folate, vitamin D. All of that are sort of subtle indicators that the child is okay. And growth, obviously, parameters like growth, anthropometry.
Right. And Arun Nair is asking, would carglumic acid be helpful in management of UCD?
Of course, carglumic is stunning. It works brilliantly, especially in acute cases, even in organic acidemias, when you don't know what organic acidemia. Carglumic acid is my drug of choice, especially if you're thinking NGS CPS. Amazing. It works brilliantly in NADS. Right. But we don't have it. It's very expensive. So if any of you are planning to make it in-house or get hold of the drug, please let me know.
Okay. So yeah, I think there are no more questions here. So we are open for the questions for the next few more minutes. Yeah. How many children born with UCD in India every year? Because he's asking again.
So I think if we get hold, what we should do is, as a cohort, apply to ICMR and make a pilot project where we pick up a thing. I think Goa did do it once, but we need to have a formal epidemiological study to look at the burden of disease. At the moment, the commonest urea cycle defect in India is toss-up between ASS1, citrullinemia, as well as arginosuccinic acid. But the exact number burden, I don't know. The worldwide is 1 in 35,000, but I think it's much higher considering, as I said, consanguinity and endogamy.
So probably it's on higher rate to increasing the count.
Yeah, definitely. But we do need an epidemiological study to
Correct.
actually get the number, which hasn't been done. And I think it's one of the things I'd like to do at some point.
Right. So one more is asking, how many liver transplants has been done so far? And what is the outcome of your CD?
Okay. So that is a very generic question. As I said, so I've come back to the country only 18 months back. At the moment, I have referred only one child for liver transplant, which I thought was appropriate and is due to have a liver transplant, has been listed. But saying that, if I were to look at my experience as a whole, from all the places I have trained, liver transplant is not generally preferred because diet, especially in UK, because we do really well with diet and early diagnosis. So neurological outcomes are better, hyperammonemic crisis is lower, and the timing matters. Very often, they do really well up until puberty, and suddenly in puberty they start acting up because they're going through puberty. And at that point, liver transplant is a pointless sort of thing, unless we get to the point where we have no other option. We do consider liver transplant for adolescents as well. So, in my experience, liver transplant has been only so the only 3 cases that I've seen who've done really well post liver transplant had very strict criteria. So, we had looked at all of the things that I mentioned in terms of indications for LT, and they have done really well post LT.
Right. Yeah. Somebody is asking that is carglumic acid available in India?
No, that's what I said. Whoever is
Yes, probably.
going to
We
make
have to import
Bill
from.
please, I'll be very happy. I'll sign up first.
Understood. Understood. Yeah, somebody is asked actually. I'm not sure. They asked they can able to import from France. Okay, if they are
Yeah,
interested
if
with
they
that.
can import it from France, we should. I'd be happy to prescribe it. It's an excellent drug.
Yeah, I hope Chetana garu kindly, get the details of the client who asked it. So
Sure,
we'll
sure,
definitely share to Dr. Krishna.
sure, doctor.
Yeah, yeah. We have one more question. Uh, I think it's a generic question. Please share details if patient can get online glutamic acid.
No, the simple answer is no.
No. Yeah. So yeah, I hope no more questions. It's a great. Thanks for the nice presentation. Summarize the diagnostic perils of IC Donac mode. Kindly summarize the diagnostic perils of IC Donac mode.
I didn't understand the question. Sorry.
I'm also not getting into the.
Maybe you can ask them to ask the question if you give them the.
Shadanagar, is it possible to ask them?
Just a minute.
Oh, so I think it was kindly summarize the diagnostic perils of UCD once more. So I think they want to know.
Okay.
Yeah.
Um, so the most important, I think, common pitfalls are you're not measuring ammonia. Simple as that. That's the earliest thing. Don't wait for metabolic acidosis. You don't have to have metabolic acidosis. They can have unexplained respiratory alkalosis. So that's one of the other things. The third thing is don't always look for a high level of thing. Amino acid within the when you get your plasma amino acids, low citrulline also should trigger you thinking about urea cycle defect. And always, if possible, pair it with a urinary orotic acid. That really helps you determine whether it's a low defect or a high defect. And that then helps us understand whether we need to supplement with arginine and citrulline. Because in certain conditions like arginemia, you can't be giving arginine. That's terribly toxic. It'll completely make the child worse. So those are the clinical decisions that I would really think about very easily. And if in doubt, at any point, I'm more than happy to be reached out to.
Yeah. Thank you. Thank you, Dr. Krishna. I hope no more questions are there. Thank you for coming and accepting the session. It was a great and pleasured session to have interaction with this. So we are looking forward to have much more sessions regarding this.
Okay. Thank you very much.
Thank you. Thank you. Thank you so much.